Thank you so much, Dr. Chan, for inviting me. I'm very excited to be a part of this, and the presentations that have been brought forward thus far have been very interesting and very timely. So I'm glad to be here. Next slide, please. Just to reiterate what Dr. Chan said, I am at Howard University College of Pharmacy, and I'm actually a community pharmacy faculty, clinical assistant professor, and I've been in community pharmacy practice for a while in the ambulatory care space. So what I want to do in the next 10 minutes is take you along with me on this journey with my one of my favorite patients, Miss Betty, who's actually a representation of a lot of the patients that I see with regards to disparities in education. And she's a Hispanic female, but it also applies to a lot of my African American patients as well. But just the lack of education and the lack of being provided education on like a continuous basis, I think is a big issue. So I will go through defining patient touch points if you've never heard of it before, and then also presenting the case and kind of highlighting the literature that surrounds the touch points. And then also presenting some recommendations for increasing those touch points with your patients. Next slide, please. So what is a touch point? And really, if you kind of research touch points, the first thing that you probably will see is it more related to business and more of marketing. So like how often do you touch base with your customer? But it's actually something that is really usable with in medicine and healthcare. And so when we think about it, it's any kind of contact or a contact spot between a patient and a provider. And this can be in many settings. It can be in the hospital, retail, urgent care, ambulatory care, any kind of extra COVID-19 clinics that we set up being in this pandemic. Anytime that you've come in contact with a patient is considered a patient touch point. And it really impacts the patient's overall experience with healthcare and with the healthcare team. So how satisfied is that patient with you and with the healthcare team based on those touch points that you've provided with the patient? Next slide. And so before I start talking about Miss Betty, I actually want to talk about or continue to expand on the touch point and what that actually means. I think that the touch points that we think about as pharmacists are, okay, if you're in the hospital and you work in, you're a staff pharmacist, maybe when you go into the patient's room, if that's your role, that may be one touch point. Or if you're in community pharmacy, when you see that patient come in to pick up a prescription, or if you're trying to provide counseling for that patient or provide an MTM service, that's a touch point, but it actually includes a lot of other things that maybe aside from being face-to-face. And what we try to do is you're trying to get that patient to really have a connection with you, right? You're trying to build that connection with the patient. So they're constantly thinking, I have this person or these people in my corner. And so with Mrs. Betty, she's a Hispanic female in her late 50s. When I initially met her, she was already coming to the pharmacy. I'm there in like I said, an ambulatory care capacity, but she had her person, right? And as you know, with a lot of our minority people, they have their person and who they feel comfortable with. And that actually tends to be the person that they talk to all the time, even though there may be other people, as in this example, pharmacists that actually should have been talking to her more. Right. So her person was actually not even a pharmacy technician, but more of a staff member that was doing a different job. But because she spoke Spanish, she talked to her all the time. Okay. So it's there, her health disparity included a language, I wouldn't say a language barrier, which I didn't put that because she did speak some English, but I think that that was a part of it too. But she had multiple conditions. So diabetes, asthma, hyperlipidemia, hypertension, chronic kidney disease. So basically a picture that we see very, very often with our patients. But because she had that connection with that person, that was the person that mainly saw her, other than her picking up the medications. But when I met her, I saw that she had all these different conditions, and I like to speak my little bit of Spanish when I can. So I used to talk to her all the time when she came in, and so we developed a rapport. And she used to talk to me more and more. And then when I found out that she also goes to a provider that I'm familiar with regards to her diabetes, then I used to follow up with her even more. So I started to establish a rapport with her before I even started going through the MTM sessions. right? So she began to get familiar with me. So then I said, why don't you come on and meet with me in the pharmacy, say next week, because she also lived close to the pharmacy. And she said, yes. So she was very happy. And then, of course, because she's in her late 50s, it was also another person to talk to. Right. So it was just her and her husband. And so she came in and I met with her and I was able to get some information with her with regards to different labs and things and go over her profile. And then I noticed that she had a couple of different monitors with her with regards to the diabetes. And that's what I highlighted on here because that was her biggest issue. Right. And so she told me that she, always took her medication. She takes them as she's supposed to, and actually had my students reach out to her physician, and we also talked to the physician as well. And the physician also said that she takes them. She said that she takes them as she's supposed to. And as I find with a lot of my minority patients, is you really have to ask the question 20 times to really get a good answer. So sometimes it stays the same for the first maybe 3 or 4 times. And then after that, it starts to adjust or change a little bit. And you get more information and more information, even as your relationship develops. So with regards to this first barrier, education, she is someone who finished early, again, like middle school. That's her highest education, which I would say was probably 90% of my patients. Okay. And then also with the stigma with regards to diabetes. So I would say on my fourth encounter with her, I actually did a house call. So I like to try to get more and more in touch with them. So I did a house call because she, like I said, was close by. And when I came, she actually had a cheese and cracker platter ready and some drinks and things because she was ready for the visit and she was very excited. So we sat down and the same questions that I had been asking her previously, I asked them again in different ways, right? And my students were actually with me. So I had 2 students. And so they, when we asked her about her medications, we wanted her, just take me through your day. What do you do? What do you like to do for fun? And so she started telling us about the center that she goes to. I said, what do you do at this center? What do your friends do? What do you like to do? We do this. How often do you go? I go this many days a week. That's awesome. So when you're there, what do you do with your insulin pen? She was like, well, you know what? I really don't want my friends to know that I'm doing that. So whenever I go to the center, I just usually don't take my insulin. It's like, there you go. So the provider really couldn't figure out why her numbers were like they were when she's supposed to be taking them every day, as said, right? And they also actually updated her regimen. So education, going back to education, I also noticed that sometimes her bottles are in Spanish, sometimes they're back in English. Her pill box sometimes is in Spanish, sometimes it's back in English. And that's not something that's like done intentionally, but I think with regards to the health disparities and these things that we're watching out for, it's just something that you have to it's just specific detail to pay attention because it's automatic to put it in English, right? And you're not even thinking about it. But the stigma also with the communities, so she didn't want them to see them injecting herself or know that she's taking insulin, right? And then the next one is wanting to please the providers. So I'm wondering why the provider didn't know that she had these issues, because whenever the provider asks her questions, she wants to tell the provider what she's thinking he's expecting to hear. It's almost like a parent relationship, right? So I don't want to disappoint the provider. And I'm sure the provider didn't have time to speak with her as much as I do and to get on that level with them to develop the relationship and the rapport. So wanting to please the providers, again, I'm using her as a case scenario, but the majority of my patients have that same issue. Um, I would say another patient, not Miss Betty, but again, with regards to hypertension, he didn't want his provider to know that he couldn't read. So for 7 years before I got there, they've been doing different things and trying different things, but didn't know that that whole time that he couldn't read, right? So I think that these 3 barriers that are pointing out, I put them on here because this is what I see a majority of the time. And with regards to the disparities, things that we as pharmacists really are good at paying attention to and really getting into, as opposed to other providers, not to knock anyone else, but we tend to have a little bit more time to try to ask these extra questions. So the result was her hemoglobin A1C went from 11.3% down to a 7.4% over that time period, which was about 8 to 10 months. After really getting to know her and doing the house calls and her coming in. And so what I want to tie in is, go to the next slide, please. We're talking about these touch points. So Kalendrian et al., they wrote an article talking about these touch points and really being in contact with your patients, trying to be in contact with them at least 7 times out of the 12 months of the year. And this 7 times does not mean just, like I said, in person, but this can be newsletters, phone call check-ins, emails, things that you want to, to make sure that they've understood from your last visit. It could be anything. And it also does not have to be with one provider. So that's why on this side with the first bullet was the key. I'm saying multiple touch points by multiple providers. So this 7 out of 12 doesn't need to just be from their physician. That includes me as a pharmacist being a part of the healthcare team and really interacting with that patient. So even though I saw Miss Betty maybe 2 or 3 weeks ago, and I don't necessarily need to, do anything with her, I have her scheduled in my computer system as a phone call check-in, just to follow up, because she's really not seeing her physician for another 2 months, right? And what I tend to see is between the times that they follow up with their physician, they were supposed to do something that they didn't understand. So for the whole 2 months, when it's time to, see the physician again, they just weren't doing anything. So in talking to the second provider, which would be us, and having that other touch point, we're able to fix whatever it is and also communicate with the provider if needed to adjust some things so that they can see the true picture of what the action plan was prior to that next visit. And then also provides consistent engagement. So in this article, they talked about the more times that you touch the patient, and with these providers touching the patient, you're more likely to increase the loyalty of the patient, them really understanding what you're talking about, improving the education of the patient, and then them being more satisfied. And that patient satisfaction is tied to better treatment adherence, and then also improvement in the outcomes that you're reaching or that you're searching for. Okay. And like I said, those 7 interactions, if we think of the patients that we have, maybe they're difficult patients, then we're thinking, oh, I definitely see that patient or talk to that patient more than 7 times a year. Right. So this is just still a basis. But I think that if you're thinking about the provider along with myself and how many times we contact the patient, but just still making sure that we have a hand out for those patients, especially the ones that get lost. So we have patients that get lost, like maybe you were supposed to see them more often, but because they've kind of slipped through and we weren't able to reach them, and then you forget about them. Now 2 or 3 months have passed, and now you really do fall into, well, did I really touch them 7 times out of the 12 months because they were lost to follow up? Okay. So having a great rapport with the patient, the interactions don't consist of just going through the motions. Are you really, really looking into what could be going on with this patient, kind of going through the social determinants of health, financially, what are they going through? They're going through things with their daughters. This patient actually told me that after their visit with the physician, okay, I'm following up on this. I know their physician in the notes said that this is what they were going to follow up on next time. So how was it? He said, yeah, I told him this and this and that, but I really didn't do any of the things that I told him because I just didn't feel comfortable, and he would be mad. Right. So really making sure that they understand that we're part of a team. I want to know what you think that you're capable of doing, and we can adjust to that and gradually change things as we go. It's not more like an iron fist. This is what you should be doing. You didn't do it. Why didn't you do that? Okay. So trust, extremely important. And then more time to talk, which I put in parentheses. I know this is a difficult one, but more time to talk, which I know was a big part with Miss Betty with the talking, because that's how I got to the point of what exactly are you doing it with this, the older person center, where you end up not taking your medicine 3 to 4 days out of the week. Otherwise, I would have never known that. Next slide. So in conclusion, increasing touch points with patients provides consistent engagement. We find out really their education level as we talk to them more, they get more comfortable with us. We see what it is that they really need and what we need to do to meet them where they are. Positive engagement with continuous opportunities for check-in and education is also key for successful outcomes. So like I said, patient satisfaction increases treatment adherence. They feel comfortable, they're loyal. As you can see you'll see in the article, more touch points, more loyalty includes or gives room for improvement for them to be more comfortable with you and to kind of actually work with you on what the goals are. And they have an understanding of what the goals are and feel like you're working as a team. Next slide. And I think that's it. So that was just a quick journey with one of my patients that I feel like when I was thinking about it, just really covers a large majority of the patients that I talk to and that I end up helping. Definitely, we're not doing the house calls during the COVID, but more of a telemedicine type scenario.